thank you for inviting us to be here with you. We hope that the information that you get will be really helpful for you and you'll be able to take it back to your practice and use it. Here are our disclosures. And here are the learning objectives for this program. We're going to talk about assessing patients for treatment with ERLA opioids, evaluate and initiate opioid therapy, how we decide, and you're going to learn to say it's a trial when you talk to the patients. Modify the dose and discontinue ERLA opioids. Yes, we do stop them, and it's important that we start telling our patients that there will come a time when they will be stopped. Manage ongoing therapy with ERLA analgesics, counseling patients and caregivers about the safe use of the ERLA opioid analgesics, and identify general and product-specific information on these medications. So we're going to have the introduction, then there's going to be a chapter on assessing patients, evaluating the ERLA opioid analgesic therapy, dose modification and discontinuation, managing the ongoing therapy, counseling and general drug information, and product specific. So why is prescriber education so important? To me, this is the key to the whole thing. If we can educate the prescribers on how to properly prescribe opioids and who are good patients to use them, we wouldn't be in all the trouble we seem to be in according to the news media. So why are we having opioid REMS? There are REMS for other drugs, like thalidomide is one that has a REMS program as well. About 35 million Americans have used opioid analgesics for non-medical use. So that means they're using them for something that they were not intended to be used for. 7 million Americans misuse or abuse prescription drugs each month. So that's a lot of folks out there. And prescription drug abuse accounts for 25 to 30% of all drug abuse. What you're hearing a lot about right now is the Chinese fentanyl that they're adding to the heroin, which is causing a lot of overdose deaths. And you need to remember that pain and addiction are interrelated. And if you look about people misusing them, pain relievers really hit the top of the list there. So understandably, as the rates of abuse and misuse kind of go up, and the sales and the deaths go up, the admission to the treatment abuse centers really goes up as well. So in 2016, the overdose deaths exceeded 60,000. So that's a lot of folks that are overdosing. And I'm really sad to tell you that they just did a research study about people who overdosed, whether it changed their behavior or habits. And I need to tell you that overdosing on an opioid made no difference to them at all. So this is partially driven by a 5-fold increase in overdose deaths involving synthetic opioids, like I was talking to Chinese fentanyl and all, and illicitly manufactured fentanyl, which is 50 to 100 times more potent than morphine, is really the primarily responsible agent for this rapid increase. In the latter half of 2016, fentanyl was detected in over 50% of the opioid overdose deaths in 10 states. The core themes that we're going to talk about here are assessing patients, initiating therapy, managing therapy. And on the left-hand side, you can see the medications that we're talking about here. So the fentanyl patches, hydromorphone, methadone. In Washington, D.C. area, methadone is really being pushed a lot because it is so much cheaper than a lot of the other extended release medications. Morphine, oxycodone, oxymorphone has been taken off the market. Hydrocodone, buprenorphine, and tapentadol. So these are the extended release medications that we're going to be, when we say these general classes of drugs, this is what we mean. And I'm going to pass it over to Dr. Clark.
Thank you, Yvonne. Thanks everybody for coming. I think that as we go through the information today, you'll see the progression and the base of the pyramid really is the actual assessment. So the idea here is one of balance. Keep in mind that the treatment of patients with chronic pain and the use of opioids should be no different than the care of any other patient with any other chief complaint or chronic illness, and no other therapy that you might consider prescribing for them. You obviously want to make sure that you understand what the benefits are in that particular group of patients and what the special risks are across different patient profiles. So the main one, of course, is overdose, and that can happen both accidentally and intentionally. Life-threatening respiratory depression, again, typically when starting the medications or making a change. Abuse, misuse, and addiction overlap with both of these categories. Everyone who takes opioids, regardless of who they are or what they do, will become physically dependent on them and can be subject to withdrawal if they stop the medications too quickly or suddenly. There's the issue of the neonatal opioid withdrawal syndrome, because now you have a passive patient who has no choice and control in what they're being exposed to. There are a variety of interactions with other substances and medications, and there also is the safety issue that relates to how people come into contact with these medicines and the patient's responsibility in terms of keeping them safe. Obviously, if you don't use these correctly, it's like any other medicine. You heard talk about insulin in the last lecture. If you don't use insulin correctly, you can die. The same thing is true here. The risks are somewhat greater with extended release and long-acting opioids because in a single pill there is much more opioid present than in a standard immediate release formulation. Now, if you think about what your patients do, all of your patients, one of the hallmarks of practicing medicine is that our patients don't do what we tell them to. 50% or more on average of your patients are not following your direction. And the same thing is true here. So while you will hear about aberrant drug-taking behavior, which really is just people doing what they are not supposed to do, it's not because they're addict, it's not because they're diverting, it's not because they're doing something else that's necessarily nefarious, it's that they just don't follow our instructions. And so that is really the rule rather than the exception. If you think about other terms that we'll be using in this context, misuse really is intentional or unintentional use of a medication for a medical purpose other than directed. And so the classic is that someone takes their opioid because they notice that it makes them a little sleepy. So now they have a night when they can't get to sleep. It's not due to pain, but they think, oh, I'll take my opioid and see if that helps me fall asleep. That would be an example of misuse. And people do this all the time. They are self-treating in a variety of ways with a whole bunch of different medications. Abuse really is reserved for the use of an illegal drug or the intentional self-administration of medication for a non-medical purpose. In other words, you're overwhelmed and stressed out, so you take your medicine to calm down. You take the medicine because you recognize that it makes you euphoric and you feel good. You take the medicine to alleviate withdrawal symptoms for something that you've been abusing or overusing and now don't have access to. Those are a special subset. So if we're going to be good stewards of these treatments and we're going to be thinking about how to keep our patients as safe as possible, we've got to be aware of the risks of abuse and misuse and other things like diversion. We have to think about how we're going to screen people for their risk of abuse in the same way we screen people for going into a surgery with anesthesia being given, and we want to assess their cardiopulmonary status. Prediction is not something we're terribly good at. If it was, we wouldn't be sitting here. I'd be doing something else. But you at least have to have in your mind's eye a sense of, this is a very high-risk patient. I got to be really careful. Perhaps this is a lower-risk patient where I'm still going to do the basics, but I don't have to be quite as scrutinizing. Mostly what we want you to develop is a sense of confidence. It gets back to that first question. If you're not confident in doing this, you won't do it, number one. If you do it, you won't do it well, and that will put all of us at risk. So the key is really education and practice and gaining that experience. You want to be monitoring this. This is not a set it and forget it kind of situation. It's a chronic disease management, and it's a chronic assessment of risk, and it's a dynamic world. You must, of course, document what you do. Our medical record now is asked to do things that it was never intended to do. It's asked to do too many things, meet regulatory compliance, bill for insurance, communicate what we do to other people, and to help us remember what it is that we did. And as we've tried to make that electronic capacity greater, we have lost the individuality and the ability to tailor the record in terms of what it is that we're doing. You've really got to strive to put in novel information, real-time information, so that you can look back at this, or anybody else can look at it and say, I saw this, I did this, this is why, then this happened, I did this, and I modified the therapy accordingly, and I was at least thinking about all these different things. Nobody expects you to be perfect. Nobody expects you to not make a mistake or to be fooled or to come across a complication, but it's how you are managing that in real time. So we're going to show you a couple of cases today to illustrate some of these points. They're not everyday cases, but I think you'll recognize elements of what you're going to be encountering when you do this. Here's Emily.
Emily is a 33-year-old woman who was diagnosed with rheumatoid arthritis 2 years ago. She first reported pain in her hands and feet to her primary care physician about 3 years ago. He treated her with over-the-counter pain medications, including naproxen and acetaminophen, none of which effectively reduced the pain. After about a year of treatment without improvement, her primary care physician referred her to my rheumatology practice, and she was diagnosed with rheumatoid arthritis. I identified moderate disease activity and initiated methotrexate. After 3 months with insufficient improvement in disease activity and function, I added hydroxychloroquine.
Hey, Emily, I have a quick question. Can you come here for a second?
This combination therapy has reduced Emily's disease activity, but she reports persistent bilateral pain in several joints in each of her feet and hands. Emily has no known drug allergies, has never smoked, and denies any history of injection drug use or drug abuse. She used to drink alcohol occasionally, but stopped when she started taking methotrexate. She works as an office manager at a local startup and reports difficulty working due to the pain in her hands and feet.
At the end of the day, I go home and sit in a warm bath and then lie on the couch. I don't go out as much as I used to with friends. That's okay, but I do miss being active.
Okay, so even in that short little vignette, you've gotten a fair bit of information that will help you think about her and how she's going to be managed over the course of her treatment. Again, this is no different than any other chief complaint. She has pain of a particular type. You'd like to know its location, its intensity, what type of quality it has, when it comes on, how long it lasts, whether it's constant or intermittent, what other patterns or relationships you might be able to discern. What makes it better? What makes it worse? Are there any things that precipitate it? And most importantly, what's her functional status and how has her symptom complex affected her ability to function? And you heard her describe a number of limitations that she has because of this. And therefore, part of the goal of treatment is not just to be pain-free or to feel like you're 20 years old again. It's to think about what are you going to be able to do functionally if this treatment is a success. So that down the road, when you're meeting or not meeting those goals, that's been something that's been declared up front. Otherwise, if you don't do that, the person will keep the target moving. And they'll keep saying, well, I'm still in pain. Well, I'm still in pain. Well, I don't know what I want to do, but I need more pain medicine. And that's the trap you're trying to avoid. You also want to be thinking about the context. Like any other chief complaint, in what world does this live for the patient? What other illnesses do they have? Will that be relevant to taking the medication, how the medicine's metabolized, what other medicines they'll be on and interacting with. Are there other illnesses that are clues to risk factors for abuse? Do they have illnesses like sexually transmitted diseases or HIV or Hep C that are putting them at risk or giving you a clue that perhaps they had a substance abuse problem or still do? And then, of course, what likely side effects are they going to experience and how vulnerable are they to those problems too? The most common with opioids being constipation. What treatments have they had in the past? Have they already had a bunch of opioids? Have they had no treatment? Have they had non-pharmacologic treatments? All of that to try to get a sense of what's it going to be like to treat this person. Are they the person that shows up and says, I've tried everything and nothing works, so this is the only thing I'm willing to do? Or are they prone to side effects, take one or two things, stop them, and end up saying, well, I've tried everything, nothing's worked for me, when in fact they haven't tried anything? So this is part of learning the patient and engaging them, and also thinking about where else am I going to be able to get information about this patient? Collateral information is key, whether it's from other providers, whether it's from family members, whether it's from prescription drug monitoring programs, whether it's from various lab tests like urine drug toxicology screens. These are all things that we need to do so that we can hone in on knowing our patient as well as possible. If things have been effective in the past, what were they? What kind of doses were involved? All of these are clues to what will the patient respond to. Do they tend to be a rapid metabolizer or a slow metabolizer? How can you begin to understand tailoring their treatment? You really must do a physical. I know that sounds silly, but a lot of times these patients show up, they've got years of pain under their belt, their charts are huge, they've been to multiple people, no one's been able to find a cause or a specific thing that they're addressing, and so it's kind of symptom management. And while you may come to the same conclusion, you'd be surprised how many people miss things. And you'd be surprised how many people very early on stop examining patients. And so, again, over 10 years, a lot happens to a human being. And as we get older, you develop all kinds of additional things, which may just get subsumed under the umbrella of chronic pain. You don't want to miss something that you could actually fix. The diagnostic testing really should be reserved for ruling in something that you think is going on or ruling out something that you absolutely don't want to miss because there's a hint of that being a possibility. If you just do screening labs and screening imaging tests and other diagnostic, I guarantee you will find an abnormal result. And then you'll have no idea whether it actually is relevant or not, but it will take you down a path of more and more workup and more side effects and more distraction and poorer outcome. And the patient will then subsume that information into their history, and they will go on to the next person and say, yeah, I have a crushed spine, when in fact they have a little degenerative spine disease. So think about how the story gets shaped over time. With Emily, she's a little bit more straightforward, obviously. She has rheumatoid arthritis. She's been treated appropriately. She has no complicating history. Her function is down, and she hasn't responded to very simple analgesic management. In contrast, there's Cal.
Cal is a 55-year-old man with severe bilateral knee pain following a motor vehicle accident 2 years ago. He runs a moving company and frequently engages in physical labor. Cal has several comorbidities, including a 5-year history of type 2 diabetes and 10-year history of hypertension.
The movers are here.
He was diagnosed with coronary artery disease last year following 2 episodes of stable angina, for which he was treated conservatively and released. Cal is currently taking metformin and sitagliptin for diabetes, co-formulated lisinopril hydrochlorothiazide, plus metoprolol for blood pressure control, daily aspirin, and sublingual nitroglycerin as needed for infrequent chest pain. For the knee pain, he has been taking a short-acting oxycodone acetaminophen product since the motor vehicle accident.
Now we gotta get this
Adjunctive treatment with corticosteroid injections in his knees reduced the pain for a few weeks, but had no durable effect.
Thanks.
On questioning, Cal says that he has never smoked, drinks 2 to 3 beers a night on weekends, and has never used or abused drugs.
You can imagine what it's like being a mover with 2 bad knees. It's a joke. What I do is often hard physical work, even as the boss. There's a lot of walking, driving. Even the driving hurts my knees, plus climbing in and out of the truck. And when it gets tight, sometimes I have to get down in the trenches with the guys. I'm the one who's responsible for getting it done.
Okay, guys.
So sometimes I have to do the work too.
The pain in my knees is getting worse. And I don't know if it's work or what, but it's driving me nuts. The doc at the time gave me those meds you take after surgery 6 to 8 times a day. I think they call them opioids. The pills did help at first, but they made me a little bit sleepy, which was okay at night, but it wasn't good during the day.
And now I'm having trouble sleeping. I wake up at night and I need more pain pills. I just sit there and watch TV until I can fall back asleep. Sometimes I just sleep on the couch. My wife is on my back now. She says I'm taking more pain pills than I'm supposed to. She doesn't like it that I don't sleep. She says she's worried that I'm depressed. I don't know about that. But I don't know what else to do at this point.
So a little bit different. You can see right away, even in this short vignette, that there are a number of concerns, risk factors, and you get a fair bit of information about the rest of his life and what is going on. So as you think about the risk of abuse in these patients and others that you're taking care of, the best predictor of what somebody will do in the future is what they've done in the past. And so you need to ask people, what have you used in the past? Have you gotten into trouble with it? Did you develop an addiction? And to what? To everything you've ever consumed, or was it just certain things? And when did that occur in your life, and in what context? Even if you get these risk factors and you discern that somebody has done some of these things or gotten into trouble, you might not choose to give them the medicine, but you might. It depends. If somebody has an active addiction, then you obviously do not want to pour gasoline on a fire. It will not go well. You will not get that person's pain better and their addiction will melt away. They will get worse. But people that have these histories oftentimes are in remission, and the situation has resolved. They're still at high risk, but it's part of the conversation, not an absolute stop. You also want to ask them about their family history, and in part to find out, does substance abuse run in the family? But also, are they living in a world where substance abuse is very common and there's easy access to these substances? Do they have a history of sexual abuse? Because that belies a certain chaos and disruption and traumatic environment that they've been exposed to, but it also puts them at risk for other psychological problems, and they may use opioids or other medicines to self-medicate. And the aspect of their social history really is to try and touch on the relevant domains of life so that you can get a sense of, is this a functioning person who has a supportive environment and is on track? Or are they living a life of chaos, disruption, and lack of support? Because that will influence your decisions. You can see that there are a ton of risk factors. And to sit and go through every single one could take a long time. But you can see that as you go through your workup and you have visits with people and they're telling you about what's going on in their life, that you'll come across most of this information. The idea is to be aware of what have they done, what have they been exposed to, what other stressors are in their life, what kind of supports do they have to get them through a difficult situation. And so with Cal, again, it's a little bit more straightforward than some patients. He has this severe bilateral knee pain after an accident. He's been treated with immediate release opioids. He has some comorbidities. We're going to assume here that he has had an appropriate workup, that he's not a candidate for knee replacement, that other illnesses like rheumatoid arthritis have been ruled out, and focus on his function and how to maximize that. And at the same time, recognize that it's not so straightforward as Emily, and there are some yellow flags here that we need to investigate. When you think about how to do some of this risk assessment, everyone always asks about what tools are available. There are a plethora of tools. You can find tools that are used by your staff or yourself, filled out by the patient, self-report, are scored in various ways, are shorter and longer, are more complicated and more simple. They all fundamentally ask the same types of questions that I have been telling you about in terms of the relevant domains of what the person has done and what is more likely to skew them into a higher risk category. You can find most of these online. You can find many of them in the public domain. You don't need to pick 5. Use one and learn how to use it well. And recognize that what it does is facilitate the relationship and the conversation about this important set of information. What you're seeing on this slide is that we're not good at predicting the future. And guess what? Questionnaires are even worse at predicting the future. So the questionnaire is not a substitute for you. It's a tool that you as an expert will get good at using. And the last bar there is an expert using these tools does way better than if you just give the person the tool and look at the score and make a determination. In fact, it makes a huge difference. Here's Cal again.
I've been telling my doc about the pain for a long time and nothing was working, so he sent me to another doc. When I went to see the new doc, he talked about a lot more than pain. It was interesting. First, he asked me to fill out all these questionnaires. The first was about drug abuse. I don't think it really applies to me. I don't know. My granddad, he had a drinking problem. I never felt like I had a problem. Then he had me gauge my pain on scales from 0 to 10. Seriously, the pain is often as bad as I can imagine, and that makes it a 10. It gets a little better with pain pills for a while, gets worse when I have to do stuff. Sometimes it's just constant, all day, all night, pain like you can't believe.
Well, Cal, based on the responses in the questionnaires, you're still dealing with quite a lot of pain. How about your function? How does it affect your work and your other daily activities?
It's more like dysfunction. I have pain in my knees all day long. I can barely work. I have to work. I have no choice. When I come home, I try to sleep. If I wake up, I take pills. I lay on the couch until I fall asleep again.
I understand. That sounds very difficult. Is the pain affecting your mood? I ask in part because depression is common with chronic pain. It can lead to people misusing the medications.
I'm tired. I'm frustrated. And sometimes I'm angry. Between the pain and not sleeping well, my wife is concerned about my change in moods.
I understand. I mean, it sounds like you're really suffering, Cal. Let me just ask you a couple of more questions. I noticed that you missed some appointments. You missed your first appointment with me, and your prior physician said that you missed your last appointment with him. Can you help me to understand why you missed these?
Geez, I'm sorry. Sometimes I get busy. I work for myself. There's no one else to take over, and I completely forgot about the appointment.
No, it's fine. I just want to understand because this type of behavior can look to us like a red flag for the misuse of opioids. You see, some people become addicted to opioids and they misuse them or abuse them. They take them more often than they're supposed to, or they use them for something other than pain, for example. Some people might even divert opioids to other people. These are dangerous and illegal activities and behaviors. Now, do you feel that you have any problem in taking the opioid you've been prescribed?
Only that it doesn't work. And seriously, the pain is ruining my life.
Okay, let's address that then. The medication that you have been taking is actually two different drugs. It's an opioid and acetaminophen, which is an over-the-counter drug. This formulation is short-acting, which is why you have to take so many. That's one problem. Another problem is that too much acetaminophen, which is the over-the-counter drug in the pill, can be damaging to your liver, and we want to avoid that.
I didn't realize that, but I'm sick of taking pills. I take pills for diabetes, I take pills for my heart, I take pills all day long for my pain. It's like I'm taking pills forever.
Well, we can switch you to a different opioid, a long-lasting one, where you only have to take it twice a day.
Sounds good. But does it work?
Let's look at that. Let's try to set a goal for pain relief. Let's try to choose something that we think is realistic.
How about 0? I know that may be unreasonable. I guess, doctor, what I would like is to get through my workday without any pain. And if I had a little extra energy when I came home to play with the kids, and I'd like to be able to sleep at night.
Very good. Well, let's see what we could do to address that. Now, there are some features to this new opioid that I want to make sure you understand. Because of the way it's designed, you cannot alter the pill in any way. You shouldn't crush it or chew it. You just swallow it whole. Now, it is designed to be tamper-resistant, to discourage misuse. Do you understand?
I guess. You just swallow them?
Right. And the last thing is I'd like you to read and sign an agreement that says that you understand how to use the opioid you've been prescribed.
An agreement? Like a contract? I have to sign something?
Well, we just want to make sure that you understand completely how to use the medication, that you take them as prescribed, that you make all of your appointments, you make sure to keep the medication away from anyone else who might want it. You want to be sure to keep it away from your children, also anyone who might steal it.
I can do that.
So Cal has some obvious risk factors. He has pretty severe pain. His function is down. But the goals with some direction are appropriate. He wants to function better. He wants to sleep better. And the patient-provider agreement, which we'll talk about a little later, is again another tool for facilitating the relationship, educating the patient, and making it clear that in this world of patient rights, we also have patient responsibilities. And that's a very important feature. There are special populations that we'll talk about later, the elderly, children, and pregnant women. The whole idea here is there are special risks for these medications in these populations, and we'll go into a little bit more detail later. Just to give you some sense of that, elderly people have a lot of comorbidities. They take a lot of medications. They have underlying changes and disruptions and slowdowns to their metabolism and their ability to handle medications. They need a more gentle approach. They need closer monitoring. And you need to be thinking about what it is that they're capable of doing, both functionally as well as cognitively, which then rolls down to, can they really manage the medicines? Are you giving them something that is likely to get them into trouble just because they're not capable of taking it responsibly and following the regimen? And there's also the issue of constipation in the elderly, which is much more common. Children, obviously, they're a smaller, more vulnerable version of the elderly. They are not typically in charge of their own medicines, so they have a different sort of cognitive limitation. There's another human being who has to be involved in caring for them and overseeing them. Is that person capable of doing this? Or does the parent have a substance use disorder or other problems that will make the child be now at increased risk? There are no good studies in children to show whether these things work or not and what the special risks are. So most of them are inferred from accidents and experience and generalization. So the bottom line is, if you're going to do this in kids, you should think about whether an expert should be involved and providing additional consultation. Obviously, in pregnancy, we have 2 patients instead of 1. They're intertwined in special ways, and then at some point, there's a separation. And so now, the baby is disconnected from the access to the opioid that you've been giving the mother, i.e. both of them. And so that baby will go into withdrawal. That is a special high-risk circumstance. Oftentimes the pain medicine is prescribed not by the OB, but by someone else. Those physicians need to be, or healthcare practitioners need to be in contact with one another. Everybody needs to know what is going on so that you can plan for how you're going to move through the pregnancy successfully and then take care of this baby. And so obviously you should be thinking about, do you really need to do this? Is it going to be a benefit? What are the special risks? And how do we make sure that that baby is okay? So, obviously the abuse of opioids is present, increasing, hopefully stabilizing, but not necessarily sure that that's the case. Mortality is increasing, largely in part because of illicit opioids and particularly illicit fentanyl. So we've got to prevent that as best we can. We've got to know what we're doing and who we're doing it to and how we're going to do it. So use the tools that are available to facilitate your own expertise and collecting a history and formulating that treatment.
So I'm going to talk to you a little bit about evaluating and initiating ERLA opioid analgesic therapy. So you should be aware of the federal laws about the Controlled Substances Act and the state databases. There are rules and regs coming down the pike that say that you're going to have to do that. And so it's important you can have the medical assistant go in and pull it up and put it on your chart so when you go in you have it. But you have to have some access to looking over what the patient has done in the past. So you have to be registered and have a DEA. You have to really do good security controls and maintain securities over what you're prescribing with your patients. And we'll talk a little bit more about pill counts and some of those things. You have to have a time limit within which the prescription can be filled. You can issue multiple prescriptions for a patient, but each one has to be dated separately, and it will say on there when that prescription can be filled. And you have to have good record keeping and work in tandem with state regulations. There was a clinic that one of the folks from the Georgia DEA was going into, and she said, I really need to tell you, when we're very concerned about the amount of oxycodone this patient is being prescribed. And the physician, being very canny and very smart, had photocopied all his prescriptions. And so when they came in there with their jackets and their guns and their handcuffs, he said, what prescription number are you interested in? And they told him, and they went back to the files, and when he produced the prescription, he said, you need to understand that that prescription was written for amoxicillin, not oxycodone. So the patient was actually going in there and changing the prescription to get more oxycodone. So it's very important that you have good record keeping. The state controlled substance regulations are really modeled after the federal ones. You can have CME that's specific to pain management. So this is a good opportunity here for you today to get some good CME. You have state monitoring programs, and you need to be in charge of the knowledge base that you have about the laws. So there are differences between the two types of medication. The IR medication really onsets in about 30 to 40 minutes and lasts for 2 to 4 hours. Okay, so if you're prescribing it every 6 hours, you're kind of defeating the purpose. So you need to remember that it really is a very short-acting medication. The ERLA can be 66 to 72 hours. It usually takes a while to start acting, as long as an hour. And so you'll find sometimes that your patients will take their short-acting breakthrough medication right along with their long-acting. Anybody have somebody that does that? Well, I just take it right along with the first one. Yeah, well, that's not how it's designed to go. In the past, we had some of the ERLA opioid medications that were coated with an with an IR opioid, so the patients got used to having the effect much quicker, and so we're very reluctant to continue with some of the newer formulations that don't have that because they weren't getting what they perceived to be the kickoff of it. The thing you need to look at is that the ERLA medications really are beneficial to you if you have a patient that is taking consistently short-acting medications. You can take fewer pills, and you saw that Cal really enjoyed that, and you do get a better pain management profile. So some of the contraindications, respiratory depression. Now, I'm not going to say that I never gave ERLA opioids to COPD patients, but it was really more in a monitored setting. I had my own consult service. I used to see about 2,500 patients a year for pain management in a hospital, so anybody could refer to me. So I saw lots of different kinds of patients. Asthma in an unmonitored setting, paralytic ileus, that would be like the kiss of death. That would be putting like concrete after cement. General hypersensitivity to opioids. So let's look at Emily again.
When I told my doctor about all this trouble I have, he asked me some questions about the pain and then gave me some tests, more like questionnaires, I guess. They asked about the pain and whether medications help. One of them had questions about alcohol abuse and drugs and stuff. That one surprised me a bit. So I filled out all those questionnaires and we talked about the results. Doing the tests, I realized that the pain is pretty bad sometimes, like an 8 out of 10 on the scale they use. The pain waxes and wanes throughout the day, but it's always there. It's the walking and working with my hands that hurt the most. We also talked about goals for pain control. I had never thought of it that way. I said I wanted to be able to get through a day at work like normal. You know, type and carry a few things and walk around the office without wincing the whole time.
Emily, I'd like to talk to you about using opioids. Have you ever taken opioids before?
No, I don't think so. This is the first time I've ever had anything wrong with me.
Opioids can be very effective for controlling pain, but they also come with some risks. You've probably heard in the news about people who've become addicted to opioids or use them for something other than pain control.
Yeah. Gosh, I didn't think about that. Will I become addicted?
Well, it's important that you use the medication exactly as I prescribed it, but based on your history and the answers to the questionnaire you've completed, you have a relatively low risk for addiction or abuse. But it's not just how you use the medication. You also have to ensure that you keep the pills safe and that you not give pills to anyone for any reason. Often, people who are addicted to opioids will try to obtain them illegally from patients who use them for pain. Can you do that?
Yes.
That's great. Here is an agreement I'd like you to sign. It's called an opioid contract. It simply states what we've already discussed, plus it asks you to keep all of your appointments and see me regularly.
Okay.
Thank you for listening and understanding this concern. Here's a prescription for a short-acting opioid. It's combined with a common over-the-counter pain medication. You can try it out for a few weeks and see how you respond to it and if it helps control the pain.
Thank you. Is there anything else I should be careful about with this drug, aside from keeping it safe?
Opioids can have some side effects. The most serious potential effect is something called respiratory depression. If you feel like your breathing slows down, you should call 911 immediately and notify my office. But we're starting with a low dose and a short-acting agent, so the risk should be minimal. Here's some information on how to handle these effects if they occur.
Okay, great.
So don't we wish that all our patients were like Emily? Yes, yes, I'll do that. Yes, thank you for the information. So I'm here to tell you that the CDC is recommending that every practice, every practitioner assess their patients for risk before they prescribe an opioid. So indeed, she was assessed using the SOAP-R. She had a very low score. She had 2, which was negative, very low risk for abuse. He did a BPI, which actually showed where her pain was and how medications affected her, and set a goal for therapy. What was her goal? To be more functional at work. So she's really looking at a functional goal, and she had no prior history. So the two things they're going to be looking for in your documentation are this screening tool and the patient-provider agreement that you've seen each physician fill out with the patient. So if you don't have copies of these things for you to look at, you can get them on the website. They're out there. And you should take it back to your practice and say, which of these do you think really fits into our practice? Now, the ORT is very short. It can be put onto an electronic medical record. So that's the one that a lot of people are choosing. But that's something that you have to look about how you're going to change your practice and incorporate these functions into it. So you can consider it a therapeutic trial. You tell them this trial can last several weeks, it can last several months, but it will come to an end and then we have to make a decision. So the conversion to long-term therapy should be based on the outcomes of the trials, how much medication the patient is consistently taking, and you need to have a real conversation with the patient about that, because some of them don't take the pills the way that they say they do. So you need to say, are you consistently taking 6 tablets of oxycodone a day, or do you just take them on Mondays and Thursdays and Tuesdays and Wednesdays you don't? Or you maybe take 2, or you maybe take 3. So you need to have a real honest-to-goodness conversation about that. You have to look at, are they progressing towards therapeutic goals? Because when they come in and review your charts, if you're not progressing towards the goal, they're going to say to you, why are you prescribing opioids for somebody who's making no progress towards their goal? Now, the 0/10 is very unrealistic for a chronic pain patient. They're never going to get there. And so what you need to do is set something that's more functional and more reasonable for them to achieve. They may have changes. They may go for surgery for their back pain that may be effective. If they're having adverse events, they say, I just have this overwhelming nausea and nothing I do seems to make it better. So maybe that's not the medication for them. If they have a psychiatric comorbidity or if they start to have some aberrant drug-related behavior. And I always like to say at this point that I had this lovely lady when she would call the pain clinic every 3 p.m. on Friday afternoon and consistently say, well, it happened again. I'd say, well, what happened again? And she'd say, well, they fell in the toilet, of course. And I would say, don't you think you might want to consider putting them someplace other than on a shelf above your toilet? So, some of them can be very canny, some of them can be very creative, and some of them can be downright in your face. So you need to actually have a discussion about that. So respiratory depression is the biggest one, and I do this presentation with somebody from Ohio who usually says, you need to tell the practitioners that their patients are going to die. So you need to take this very seriously, and you have to instruct the patients to call 911. And sometimes when those kids do those fishbowl parties where they put all the pills in and take out one and they get into trouble, the kids get all nervous and they don't really want to call 911. But they actually have to have that in their mind that if this is an issue, respiratory depression should result in a 911 call. So the respiratory depression, people with obesity, lung disease, sleep-related disorders, older adults, they're all at higher risk for respiratory depression. So for some of the patients that I see or saw, I would really advise co-prescribing naloxone for them. And for a patient in particular, because some of them aren't going to change their spots. If they're coming in with respiratory depression that's life-threatening, they're probably not going to change. So I had a patient who thought it was a good idea to drink a 6-pack with his extended release Dilaudid. He was taking 32 milligrams twice a day. And he decided to drink a 6-pack out on the patio and stood up and fell over and hit his head on one of those barbecue islands and gave himself a bleed, and they had to evacuate the hematoma. And I sensed that he was not the kind of patient who was ever going to change his behaviors, that he felt that was perfectly okay. So I co-prescribed naloxone for the wife. I gave her a prescription and I told her how to use it. because before she calls 911, she needs to hit him with it and then immediately call 911 so that she can save him, because he ended up in the ICU with a cranial bleed, and that is pretty significant. So I think it's important for you to assess your patients for the appropriate patients who might benefit from a naloxone prescription, and it's over the counter now as well. So that's something to consider. There's an increased risk with the elderly, and I had a lot of elderly patients. I took care of a pair of 104-year-old twins who I thought were completely with it till I saw them reading papers, but they were turned upside down. So you have to really assess your patients for your opioid therapy. But the thing is, they can tolerate small amounts. There's no reason why an elderly patient who falls in a nursing home and breaks a hip can't have some opioids to relieve their pain. Look for the other drugs they're taking to make sure there isn't anything that's going to add to the respiratory depression. And again, you have to do proper dosing, proper titration with these medications, and do not overestimate the dose of the medication needed when you're converting a patient from one medication to another. And you have to instruct them just like Cal. You swallow the tablets. You don't chew them. You don't adulterate them. You don't do anything to them. You just swallow them. As Cal said, you just swallow them. So you initiate the treatment. You make the drug and dose selection. And a lot of the medications in the ERLA formulary there should really be only used for opioid tolerant patients, those that have been taking opioids for a week or more. You monitor them more carefully when you start them, and you titrate them for need and whether they're tolerating it well. So let's look at Emily again.
I took the Vicodin as my doctor told me to. It definitely helped. I really noticed it when I was at work. I have to walk around the office a lot, and the first day that I went back to work after taking the opioid, I found myself walking around thinking about all the stuff that I had to do instead of the pain or trying to avoid it. It was a real eye-opener. I hadn't realized how long I had been in pain or how much I had adjusted to it.
You need to understand that tolerance and dependence. Tolerance is when the effect of the medication becomes lessened for some reason. Dependence, they're all going to become physiologically dependent on the medications and are not totally equated with addiction, which is a psychological condition, and it is chronic. So opioid tolerance, the patients have to be opioid tolerant before you start using an ERLA opioid. So it's important that you understand they need to be taking 60 milligrams of oral morphine a day, and that is, again, consistently every day for a week. 25 micrograms of a transdermal fentanyl patch an hour a day for at least a week. 30 milligrams of oxycodone a day. And how much is that? That's 6 tablets, right? So 6 tablets of oxycodone a day for at least a week. 8 milligrams of oral hydromorphone a day for a week. Oxymorphone is no longer available, I guess. No? Yeah. And equianalgesic dose of another opioid. So if your patients are not consistently taking, the equivalents of these opioids, and you are not sure that they've been doing it, you really have to be sure before you're converting them to an ERLA. So here's Emily again.
I would say the biggest problem with the Vicodin is that it doesn't last very long. I kept having to take more pills, like every 4 or 5 hours, it felt like. And before my next dose, the pain would start to come back as bad as it was before. When my doc asked about function, I told him that I could do a little better. I could type a little bit longer and walking hurt less. But I still have trouble making it through a work day.
So here's the summary for this chapter. Know your local and state laws. Use a patient prescriber agreement before starting an opioid trial. For me, the PPA is the rules of the road for giving patients opioids. It tells them what medication, what dose, what's expected of them, what's going to happen. You should have no problem getting a random urine drug screen from these patients because they've signed their name saying that they expect it. You should look at the risk factors for respiratory depression and understand that a lot of these opioids can only be used in opioid tolerant patients. Start with low doses and titrate upward, and monitor for symptoms of respiratory depression.
Now we want to talk a little bit about opioid rotation. The idea here is that you're going to switch from one opioid to another. There are a variety of reasons why you might do this. The first opioid might not be as effective as you were hoping for, and you'd like to try to increase that with a new agent. People respond differently to these medications. Even though they're all opioids and they all affect the mu receptor, they have different profiles, and people are built differently. And so they have different responses to different opioids. So we're not all the same, the medicines are not all the same. They may be having adverse events, they may be better, they may be wanting to minimize the amount of opioid and hoping for a decrease in dose with that conversion. There are a whole variety of reasons that this might come up. The idea is that when you make that switch, you have to be aware of a couple of key concepts, the most important of which is this idea of incomplete cross-tolerance. So that as people have taken one opioid and gotten used to it, their risk of respiratory depression, most other adverse events except constipation, will gradually go down. But then because you're switching to a new agent, that cross-tolerance doesn't necessarily carry forward in the same way. And now they are at increased risk for all of those effects again. Maybe not quite as intense, but they can certainly reoccur. So you want to be thinking about, how do I make that switch? How do I prepare for that risk? How do I guard against overdosing somebody or giving them too much or overestimating the conversion? Part of what drives this, as I mentioned, is that we're built differently. And our opioid receptors are built from different subunits. And those subunits exist as genetic variants across our parents and our ancestors, so that depending on how they get put together, a mu receptor can look very different. And because it's a different lock, now when you put in a different key molecule, whether it's fentanyl or heroin or oxycodone, you may get a different response across different individuals. So you need to keep that in mind. And you will see that people have a whole variety of responses. You all have had the experience that some people get nauseated and vomit with morphine but not oxycodone. You can think about that kind of inter-individual variability with all the different effects of these medications. Then there's the aspect of how the drugs are metabolized and processed by the body, in addition to how the drugs affect the body. There's a whole host of factors. You cannot plan for this or map it out as cleanly as you would like. All you can do is be aware of these potential differences in effect and try to guard against a disaster. The conversion process is one that you've heard about, and maybe you've seen these tables. Now there are calculators online, some supported by the CDC or NIDA or other professional societies. Use something. Use it in part to teach yourself and become familiar with how you move back and forth, but also as a backup. Because it's easy when you're doing these kind of switches to get the direction mixed up or to move the decimal point too far, and suddenly you're in a problem. The thing to remember is that none of these were produced or designed after well-controlled studies in patients like this on these kind of medicines. So they are purely estimates. They're good estimates, but they're not perfect. And they can vary even in going different directions. So for example, if you're converting somebody from methadone to something else or vice versa, it can be a very different ball game. So you want to be careful, and you want to be thinking about how to cut back And most of these calculators have an option to say, has the person been on opioids for a long time, or do you want to build in a hedge factor? And typically we recommend a 50%. So you do the conversion, and then you cut that second dose by 50% and start there. This is not something you want to do on a Friday afternoon when you're going out of town on vacation. It's something that you want to prepare the patient for, and it's something that you want to say, look, we will manage this in real time. I need to hear from you whether you're doing okay, whether you feel over-medicated, whether you feel you're in withdrawal. So you want to be conservative. It's easier to increase than back off. You want to be thinking about whether you have a patient who is sophisticated and compliant enough to have some small amount of immediate release medicine so that if they do go into withdrawal or their pain spikes, then maybe they can add the medicine in and help you figure out what is the total daily dose that they're going to eventually need. That's a special circumstance. Once you've got somebody in a steady state and you feel like they're on the amount of opioid that they're going to need, if there is an IR component, you want to roll that into their long-acting formulation because you want to move people away from immediate release drugs for a whole variety of reasons. The idea here is that you want to be able to switch people. The reason why you're switching is because you're trying to get your management to a more sophisticated, effective, less side effect prone, less risk situation. So it is a dynamic process. It is one of reassessment and monitoring. It is one of saying, how are you doing? Have we met the goals? Do we have a room to go? Do you want to keep on this medicine, or do we need to look for a better alternative? And making those switches in a controlled, cautious way. Again, if somebody has a poor response to opioids, they might have a better response with a different opioid. If the person has some preference for, because of side effects or because of timing or cost, insurance coverage, you take that into consideration and say, well, maybe we should switch to this and see if that addresses these issues. If somebody truly has a preference for a particular drug and there are other signs of addiction, other aberrant drug-taking behaviors, other red flags, abnormal urine toxicology screens, then it may be that they have a preference for that drug because that's what they like to abuse. And that may be something to move away from, obviously. It may be that over time people's bodies change and they develop other illnesses or they're on new medicines and now you have to reevaluate dose or formulation because of those pharmacokinetic or pharmacodynamic reasons or the presence of other drug-drug interactions. So I can't stress enough how important it is to stay engaged in real time thinking about how you're going to change the management because this may be something that goes on for decades. Here's Cal again.
Overall, the pain's a bit better. It's not excruciating. I get around a lot better. I take the long-acting pills twice a day and the short-acting pills 6 to 8 times a day. I still have some pain. When I went to the doctor, he asked me when I have pain, when I take the pills, and if I have any side effects. I still have pain when I pick up heavy stuff at work and when I walk for long periods of time.
Okay, so I want to spend a few minutes just talking about this concept of breakthrough pain. That in and of itself is not easily defined. The concept is that somebody has a baseline level of pain or reduced pain on an extended release formulation, and then for whatever reason has a spike. Maybe they come spontaneously, maybe they're provoked by an activity or procedure, and then the question is that happening frequently or in a predictable fashion and causes so much distress or disability that you would give that person an immediate release medicine to take at that time to kind of push down that whack-a-mole head? And what you don't want to see is that you prescribe an immediate release opioid and they're taking it round the clock day after day after day and going through that 120 or 180 every month. That's not breakthrough pain management. That's another problem. So you either need to raise the extended release dose to get a more chronic, a better control of persistent pain, or the person does not understand the instructions, or they're using the immediate release opioid in an unintended way. You also need to think about other therapies to manage that breakthrough pain. If you hear nothing else from us today, we're not telling you to prescribe opioids to everybody. We're not telling you that opioids are the panacea. We're not telling you that all forms of opioids should be used in every patient, or that any pain needs an opioid, period. It's a thought process, and it's one of many ingredients in the patient's therapy. So think about what else you can do to manage that exacerbation.
Yeah, the pain's a lot better, but it's not enough. When we were talking about treatment goals, I said, how about enough to get around, go to work, play with my kids? But when I rate the pain now from 0 to 10, it's better, but it's like a 6 to an 8. When I asked about something stronger to relieve the pain, first he increased the long-acting opiate. And when that didn't work, he suggested something that works on the nerves. It's called duloxetine. I take it once a day. I will say this. I do feel like I have more in the tank and I'm getting around better. My wife's happier too. And you know, that's as good as gold.
All right, so Cal's not the perfect patient, I understand. And it depends on whether or not you think Cal's pain has a neuropathic component, whether there's a myofascial element, whether it's related to other things in the way that he moves, or the strength that he has, or the flexibility, et cetera, et cetera, et cetera. Think about the way in which to address the whole patient. Think about ways to tailor it. The use of antidepressants like SNRIs and tricyclics or anticonvulsants is horribly underutilized for neuropathic pain, and are oftentimes remarkably effective. Similarly, you cannot shortchange physical fitness, flexibility, strength, core muscles, all of the aspects of us that we need to address all the time. And think about how it is that you can add and adjust your recipe to get people to a better endpoint. Obviously, these medicines have side effects too. NSAIDs have their own toxicities. Antidepressants have different effects. Some are lethal if overdosed with. Anticonvulsants will oftentimes produce some cognitive side effects. So you've got to be weighing all of these as you prescribe to people. We've talked a little bit about using IR and ER together. See that, again, as a refinement of therapy, not an endpoint. So you want to also incorporate non-pharmacologic strategies. All of you are sitting here today because you have coping skills. Oftentimes our patients have none of this. Remarkably little. They wake up and they think, I don't feel good, so I'm not doing anything. And that's what we're trying to help them turn around. It's a paradigm shift for many of our patients to say, how are you going to overcome all of the daily barriers to being as functional and productive and have a satisfying life as you can have? Medicines are not the only answer. It takes other things. Again, remember that there may come a time when you say, we're stopping this. Because it's worked and you're better. Because it's not working, we want to change. Because you're doing something you shouldn't be doing. Because the medicines are doing something to you that they shouldn't be doing. So think about that up front. Warn the patients that this is coming. And then say, look, we're at this point. And we need to do better. I'm not refusing to treat you. I'm not saying we won't do other things. What I'm telling you is we can do better together, and I'm going to help you get there. So when you stop, don't stop them suddenly. Don't back down to immediate release drugs and then taper. Don't make huge cuts. The point is a gradual glide. And if you do that, the medicines will help you because of their long-acting properties, and you'll minimize withdrawal symptoms as opposed to what you might see with immediate release drugs. The actual amount varies from person to person. If it's 10% a month, you're making progress. If it's 25% every week or every few days, and the patient can tolerate that, so be it. Tailor it to the person. The withdrawal syndrome from opioids is rarely fatal or life-threatening, and except for very critically ill patients. It can be tremendously uncomfortable, but it's unusual in this scenario with these agents. We'll finish up
I've
with
been
Cal.
keeping all the appointments like the doctor told me to, and the new pills are helping me sleep better. I take one pill at night before I go to sleep, and I don't have to take all those pills all through the night. They make me a little bit tired, but that's okay.
All right, so remember, the use of these medicines varies for opioid-tolerant patients. A lack of efficacy can be addressed through rotation or supplementation with other opioids or other therapies. Be conservative, go slow, make gradual changes, and do the same thing when you're stopping them.
So what about compliance monitoring? And I'm sad to tell you that I do expert witness testimony and have done it in the past. I really hate to do it. And the reason I really hate to do it is when I get an MP or a PPA chart on my desk, some of the things that I find most often are that the compliance monitoring is lacking. And therefore, we're going to have somebody get into trouble. So I don't like to do that. So the purpose of compliance monitoring is to look at previous or current drug use. And as Dr. Clark said, if you have somebody that is currently using illicit drugs, that is not somebody you should be using opioid therapy with. You should not, but you should send them for Suboxone. The CDC says if you screen somebody who comes back high risk, you should be sending them for Suboxone or methadone treatment. You shouldn't be trying to struggle with them in your practice. You should determine the basis of the treatment, and it really helps implement adequate pain management strategies because it gives you an idea of what you're actually seeing. So you can use the screening test, and I've told you the CDC is telling everyone that they should use one of the screening tests, whatever one you choose, you should have it available. The patient prescriber agreement, again, the CDC is coming down with that. And patient education, they'd like you to educate the patient about the medication. The state PDMP's medication reconciliation. Now, I need to tell you that if you're having your patients come in with pill counts, you have to be very, very perceptive because there isn't an opioid made that is not being counterfeited on the internet. And so what they are sugar pills designed to look like the medications you're prescribing. So you have to be a little perceptive to look and make sure that they actually look genuine. The UDT, we're going to talk about those in more depth. So informed consent. When you give a patient a drug, an opioid, you have to get informed consent, and the patient prescriber agreement is an excellent way to do that. It actually looks at the goals of treatment. It actually puts them down in writing. The expectation, what the risks may be to the patient. You heard the doctor talking to Emily saying, well, are you afraid about being addicted? What about addiction? He was talking to her about that. And alternate treatments. The CDC is mandating now that you start with a non-opioid and use non-pharm treatments. And so physical therapy has become very, very popular. The potential for how to manage common opioid adverse events that they might have, other serious risks, and it talks about hyperalgesia. Hyperalgesia, if the patient has been on chronic long-term therapy, they may be that patient who comes into your office and says, I hurt all over. I can't stand for my clothes to touch me. I don't hurt just where I used to hurt. I hurt everywhere. And the solution to that is to reduce the dose. So look out for that patient. And you can have endocrine dysfunction. Your gentleman patients will be experiencing erectile dysfunction, and your female patients will be experiencing loss of libido. So you need to have these conversations with them. So I'm a firm advocate of the patient-prescriber agreement because it sets out very clearly what's going to happen, and it also outlines an exit strategy so that you can say to the patient, you know, your screen came back positive for, you know, some kind of illicit drug, and you say, well, you know, really I think that's problematic here, and maybe we shouldn't continue with the therapy. And I just have to tell you that these people come from everywhere. They just aren't the guy that's sleeping under the bridge. It is anybody. I had a lovely girl who had been in a bad accident out on the Beltway. Nurses said, you have to see her. Her PCA is not working well for her. There's something wrong with that. So I went and said, what's going on with your pain management? And she said, well, every time I push the button, I don't feel anything. And she said, it's broken. I'm not getting any medication. I said, okay, and knowing full well that I had her urine screen in my hand. And she was a lovely girl. She would be, you know, you'd be proud, anybody would be proud to have her as a daughter. So I said, well, let's talk a little bit about. So why are we seeing some marijuana in your screen? And she said, well, it was a very good first date. It was a very special first date. And so I was very nervous, so I wanted to relax, so I smoked a joint. I said, okay. So I said, and then about this anxiolytic that's showing up here. And she said, well, I told you I was very anxious, so I took one of my mother's nerve pills. I said, oh, really? What was that? Xanax. I said, so again, I'm asking you, do you have like migraine headaches or low back pain? Because I'm seeing an opioid show on your urine screen. She said, no, I told you it was a really special date, so I shot some heroin up. So for patients like that, you need to have an out. I mean, you do not need to have people like that in your practice for whom you're prescribing opioids. I told her, I said, I don't believe there's anything wrong with the PCA, but we'll change the dose. You know, and the thing is, she could have been anybody. I used to treat heroin addicts, and I would treat them for their pain while they were hospitalized. So I know that there is a huge amount of medication that can be given to these patients. And sometimes when they say it's not enough, it may be, as Dr. Clark indicated, cross-tolerance. It could be a lot of different things, but in some cases it is because they've been using other things. So it really gives you informed consent, patient-prescriber agreement. It clarifies it, and it gives you an exit strategy, and it tells the patient, if you do something wrong that we haven't agreed to, if you go to 30 doctors looking for pain medication, that's not right. It's showing up on the state screening, the drug monitoring program. That's not somebody you want to continue with. So this, to me, is the rules of the road for what you're prescribing for your patients. So it designates one pharmacy for filling the prescriptions. And there are some of the drug monitoring programs that will show you that they have a coding on there that shows you your patient is paying cash. So you may want to have a little talk about that too. Explains the importance of having one clinician. I had a great doctor try to follow me on pain service. She came out, she was an anesthesiologist. She said, well, you know that lady down in the B hall, she was really complaining that she wasn't getting enough medication for discharge. She was sure her abdominal pain would be not cared for adequately. I said, really? She said, so I gave her an extra prescription, and, you know, I hope that helps her. I said, okay. So 2 weeks later, the doc came back on the floor, and she was stomping around, and she said, well, I have just been informed by the giant DEA that I am one of 30 physicians prescribing Percocet for that patient. So one clinician, one person only. The importance of taking the opioid as prescribed. When the prescriptions will be refilled. Don't be calling in the clinic early because they're only going to be filled every 4 weeks, every 6 weeks, whatever. The compliance monitoring that will take place, how to safeguard the medications, how to discontinue the opioids, and places for signature and dating. And people always ask me, do I start it when I give the opioid prescription? Yes, that is the time you do it, so that you don't get 6 weeks down the pike and get into a problem. So when you're looking at your patients, you need to monitor them for analgesia. How good is their pain relief? And I'm not really big into numbers, I'm more into functionality. Can they do their activities of daily living? Do they have any adverse events? Are they having constipation? Are they having respiratory depression? Aberrant behaviors. These can be very, very dramatic or very subtle. So you have to really make sure that if you find something's going on, that you discuss it with the patient and say, we need to have a talk about this because it isn't correct. You know, the lady with the pills falling in the toilet 3 weeks in a row. I mean, come on. She needed to put them someplace different. And you need to continue looking at the therapeutic risks and benefits. Is the patient getting better? Is she or he progressing towards their goals? You need to look at who's benefiting and who's not. Who needs additional services? Maybe somebody needs to go to counseling. And when the risks outweigh the benefits, you got to say, this is not the right approach to this patient. And again, periodically reassess the need for opioids. Do they continue to need them? I will tell you, I have a friend out in Seattle who worked for a very heavy, big brand name cancer group out there. She was an MP, she ran a clinic for cancer survivors. And her whole clinic was filled with addicted cancer survivors, true addicts. And the reason they were because they felt that when their cancer resolved and they no longer needed the opioids, that they should continue taking them because they were afraid the pain would come back. So she had a multi-dimensional clinic where she had counseling, support for the patients, and then would wean them off their opioids. So it's important to look at these patients too. Patients with chronic pain who go along forever, who think that if they discontinue their medications, their pain may get worse, may come back at the same level, that there is no need to even try to taper them off. And the CDC has a nice booklet about how to taper patients if you go to their website. So, you know, they say lowest dose, shortest possible time. So you have to keep monitoring the patients, monitoring their compliance, and trying to see how the medications are affecting the patients for the good, for the positive. So you have to periodically do the pain control, functional outcomes, quality of life, adherence, and the ones with the high risk that we talked about already, the elderly, pregnant, and kids, really need to be monitored more. And so here's Cal and Emily.
It hasn't been all good. I started having constipation with the Vicodin, and it continued with the new drug. I still feel a little constipated. I eat stuff with fiber and drink lots of water and take laxatives. It helps. Also, I feel drowsy sometimes. That has gone away recently, but at first I was like, is this it? I'm either in pain or I'm too sleepy to think straight. But that has gotten better.
When the doctor asked me about side effects, it was a little bit embarrassing. It's a little bit of a challenge when I have to go to the bathroom. Not with number one, but with number two. So a good day is going to the bathroom before noon. It's really unpleasant. So the doctor told me to take fiber, drink water, and he prescribed some laxatives for me. Sometimes I feel like I'm 100 years old, drinking fiber drinks instead of kicking back with a beer. But the laxatives, they do help.
So that's our folks. They're going along and they're just being more functional, but they're having a few issues there. So some of the ones that you're going to find, always constipation. Constipation is never going to get better. The recommendation from the Geriatric Society is no longer to give elderly people the bulk laxatives because they don't drink enough liquid or aren't active enough to actually mobilize all that. So to use a different kind of laxative for them is recommended. So you really have to have a good talk about this so that people understand you're interested in making sure that your treatment is going to be successful. And part of the success is making sure that they are not totally constipated up to the gills so they stop taking their medication. Some patients will stop taking opioids if the constipation becomes severe enough. So nausea and vomiting tend to diminish over days and weeks, so they just have to hang in there and you give them something for the nausea and the vomiting. Drowsiness and sedation tends to diminish as well, and pruritus and myoclonus will actually dissipate. The respiratory depression, as we've kind of beat it to death here earlier, is really the most serious because it is life-threatening. So you have to make sure that they understand how to monitor it and that their interactions with benzodiazepine and some of their herbals and other medications can actually exacerbate the effect. So it's good to do a medication review to make sure that you're not getting to a point where it might be threatening. Hyperalgesia, I've talked about that, the patient that hurts all over. And sleep disruptions. Sleep apnea is an issue. Not all sleep apnea patients look the same. They aren't the heavy gentlemen and women with the large abdomens. Some of them can be very thin and very petite. So it's important to ask other people in the family about the snoring patterns and the sleep disruption, the breathing disruptions they have. My ex-husband used to have a sleep disruption, and when he would go on reserve training with his colleagues, they would make him sleep in a separate room because it sounded like there was a truck. And they said, "We thought there was a truck outside last night." So, yeah, ask others. They will tell you. The 4 C's, when you're looking at substance abuse, these people are very different. Their whole attitude towards their substance is they cannot stop it. They really are, they understand it's very harmful, but they can't stop. They just like it too much. The impaired control over use. They couldn't stop using it if they wanted. They compulsively use it. They think about it all the time. They are in search of their next hit. So they are really very different with that. You look at high risks for misuse actually decreases the likelihood that you will have a successful pain management pattern. So you develop a monitoring strategy based on the risk. You already risk assess them, you know where they fall. And frankly, it doesn't take much to get into that moderate level. I have a friend who I used to do talks with, and he would say, it doesn't take much. In my case, he said, I have about a couple drinks every day. He said it doesn't really take much to get in there. So you look at your PDMP, make sure you're doing that, your urine drug screen, pill counts, and frequently assess their behavior. And you refer them for substance abuse treatment if necessary. And SAMHSA has a list of places to send them if you are not needing that. So you should increase your monitoring if you have somebody calling in all the time for early refills. If they're misusing alcohol or illicit drugs, if they're coming to the clinic drunk, some of the folks that I used to see down in Florida would come in with their best friend, Johnny Walker, every time they hit the clinic. It would be like, whoa. So you have to make sure you're assessing them. If they're taking larger doses than prescribed, and you're going to have that finding out, they may use all their medication in the first 2 weeks. They may think that that's the answer. They may lose their insurance, and not be able to have their medication. But this dosing, the larger doses, more is not always better. Insisting that higher doses are needed. I need more. Well, you have to see whether the pain relief is adequate or if there's an issue with that. Deteriorating function and obtaining opioids illegally. That's really hard to track down. The urine drug screen will probably be your best friend there. What do you do if the prescribed opioids are not present on the urine drug screen? What are they doing? Selling it. Always? Always? Not always. As I said, some of them lose their insurance. Some of them have this strange pill-taking behavior that when they get their prescription, they use all of it in the first 2 weeks, so there's nothing in their system by the time they come for their drug screening. So you have to have a talk with them. You have to say, what's going on? I see we've got this problem here. It's not always diversion, but you always have to have a conversation. And if they're not going to their yoga or physical therapy appointments, it's like, well, what's going on? Should I really continue prescribing for you? So you address it. Some unsanctioned dose escalations, unapproved use, openly acquiring similar drugs from other. I like this one, the prescription forgery, because if you think it can't happen to you, it can. It happened to me. I was working for the University of Florida in a community health clinic during some of my training. And the pharmacist said, you know, I think somebody's stolen one of your prescription pads. I said, really? Because that was back in the day when you did the handwritten thing. I said, really, why do you think that? And he said, well, we just had a gentleman down here who put a prescription through the transom for morphine, MORFEEN. 1 pound dispensed now. I said, yes, I guess we have. I said, is he still standing there if he was dumb enough to do that? And he said, no. He said, as soon as I picked the phone up, he ran away. It's like, So it was out there. So yeah, it can happen to you. And if you don't know, you know those little finger polish remover pads that you can get in the drugstore? For a handwritten prescription in ink, they can just take one of those little pads and rub it over twice, and all the writing disappears. And they can write themselves anything they would like, and your name is on there and all the other information. So yes, prescription forgery, or they'll take a 1 and make it into a 7, whatever, and obtaining drugs. So, you know, you need to be doing these monitoring programs, and we talked a lot about this. Do remember that not all organizations contribute to the PDMP. So Indian Health does not contribute their data. Some VAs do not contribute their data. So if you're sharing a patient with the VA, make sure that their VA is contributing the prescribing data into your state PDMP. So, you know, the patient very often does not know that the report's been generated, so it's not something that you feel you have to really explain to the patient all the time. It's for your own safety. And it should be that you want to look at your own prescribing habits in addition to the prescribing that, you know, to make sure that they're not getting in there and changing things. And like I said, they can erase it if you're handwriting them. So like the clinic where they came in with the DEA, he was writing amoxicillin. He was not writing oxycodone. So, so have you had something happen?
I can't think of anything quite so dramatic, but certainly in the days when online printing came into effect, I had many people actually try to reproduce my prescription pad on their own. So they didn't really have to steal it; they just made it. And a lot of people had their DEA numbers printed on their prescription pad, and I never did that because I always wanted to be able to write my number myself in the same way that you would not have your signature printed on the prescription pad.
So if you think it can't happen to you, it may. And it may be happening and you don't even know it. But if you look at the monitoring program, you'd be able to see it. Like, I would never write that for that patient. I would never write 250 for them. So you have to make sure that you look at your own stuff. Now, the urine drug screen testing, there is no excuse for not doing them on a random basis. And for the patient who comes into the clinic and says, oh, I just went, I can't go, you just sit them down and say, there's all the water in the world in this clinic. We'll just give you enough glasses until you can go for us. So you cannot let the patient talk you out of it. So they should be used in all your patients that are on your opioids, and you can identify both prescription and illicit drugs, but there are some refinements to that. can be used to assess adherence, and you can look at any discrepancies in your urine drug screens as a way to open a discussion about, why this is important. And as a note, I will tell you that there is a prosthesis available on the internet called the Wizinator. It is a leg bag that attaches to the gentleman's leg, and there's a prosthesis so that it looks like the gentleman is providing you with a sample, but really the urine in the leg bag is what is being provided to you, and he's purchased clean urine on the internet. So if some of your male patients show up pregnant, you know that he's got a faulty source. So what do you do with the urine drug screen when it comes back? Your point of care testing is very generalized. It'll give you an idea of what the patient has ingested over a short period of time. So you should look at your own office drug screen and know what is going to show up there, what it's possible of providing to you. The only thing it shows you, if you got a positive result, is that there's recent use. It's not going to tell you, it's not going to diagnose addiction, tolerance, or dependence, and it doesn't tell you what dose they took or frequency. It's just going to show you that sometime in the recent past they put that in their body. It does not identify diversion if you get a negative result, as I said, but as again, it may be due to the maladaptive drug taking that the patients are doing. So what you need to understand about these tests is the point of care is fairly limited. So if you have a negative result, it can be caused by no drug. As I told you, the patient may be binging, taking it in a different way. Some of the assay actually binds very weakly at times, and other medications can interfere with the result. So there's always, on the point of care testing, a possibility of a false positive or a false negative. So here's the difference. When you want to have something where you have a real suspicion there's something really going on with this person, you send it for gas chromatography, which is a confirmatory urine drug screen. It's going to be very high sensitivity. It's going to be able to tell you about some of the semi-synthetic and synthetic drugs that are maybe the patient is ingesting. It'll show you a very slow turnaround, so you're going to have to wait for the results. But you can use these results in court, so it's really a lot higher quality than the point of care testing. So here are some referral sources you can have if you have a patient that's in trouble. You can send them to Dr. Clark for treatment. Or you can send them to one of these referral sites here. So here's the summary for this. I hate to make it sound like it's burdensome, but you do have to follow up with your patients who are on opioids. You have to look at their screenings. So the goals of opioid therapy are really to improve the quality of life, the functionality, like you see Cal and Emily improving their functionality. I really, go on the internet and look at the patient prescriber agreements that are there. You should be using one of these to protect yourself and protect your patient. Use your drug monitoring program, and really, urine drug screens can really be a savior. Let me tell you, when I was talking to that girl, I had everything I needed right in my hand. So it's important to have that information to use when you're talking to the patient. And be sure you monitor your patients for their analgesia and such.
All right, let's talk about some of the other ancillary issues that come into play with these medications. So now I want to talk about a different document, the patient counseling document. It is a complement to all of the other tools and forums that we've talked about. Again, emphasizing the need for facilitating the relationship and the conversation, providing education, making sure that people understand the risks and the expectations, and how to get help and what to get help for. So these can be tailored to individual medications. They can be tailored to individual patient factors. You can download them again from the public domain. And basically they're trying to provide another source of quickly accessible, clear steps for if this, do that. What you want your patients doing is reading the medication guide, which I know all of you do, and you would never throw this away in the pharmacy before you've actually left the store. You would take your medicine exactly as prescribed. You would store your medicine away from children and in a safe place. I would say that this is probably an instance in which you would want medication stored in a lockbox. That you would be surprised at how oftentimes people look in your medicine cabinet. If you leave your children alone, they go through all of your drawers and look around the house to try and figure out what is actually there and why. And people come into your house and look around. So sometimes people that you think are your best friends. This is something to keep special and to be off the beaten path. The controversial thing on this slide is to flush unused medicine down the toilet. It's not my recommendation, it's the FDA's recommendation. The purpose for that recommendation is that it takes the medicine out of immediate accessibility, as opposed to putting it in the garbage or putting it in a landfill or something like that where somebody might come across it inadvertently or by design looking through it. The best option really is drug take-back programs where health systems and police departments make the opportunity available to you to bring the medicine back with no harm, no foul, and to facilitate getting it out of public access. What don't you want your patient doing? You don't want you giving your medicine to other people. This too is much more common than you realize, as people will say, hey, you look like you're suffering. Here, I take a medicine for pain, helps me a lot, try mine. Or somebody says, hey, I know you're in pain and you take that medicine, you look like you're doing well, I'm in pain, can I have one? And if people don't think about that in advance, it's oftentimes they don't know what to say. And so they don't want to say no, and they don't want to be embarrassed, and they don't want to be a bad friend, and they don't want to be a bad person, and so they say, oh, okay, well, what harm could that do? And you all know what the harm could be. So don't let your patients do that. Tell them how to handle that situation. Don't take the medicines unless it was prescribed for you. Don't discontinue these things without talking to me, because you will go into withdrawal and you'll have other issues that will arise. Don't adulterate the pill or the patch. Use it as manufactured. It's manufactured that way for a reason. It's manufactured that way to keep you safe. And the last one is also somewhat difficult for patients because you're asking them not to drink alcohol. And many people in this room do consume alcohol. And they do that socially, and it's an intense part of our social and public interactions. A lot of people will have a glass of wine with dinner. A lot of elderly people will have a glass of wine or two to help fall asleep at night. And now you're asking them to take opioids. And people will say to you, is it really that big a deal? Isn't it okay if I just do this? I'm not an alcoholic. Well, the truth of the matter is it probably could be a big deal, depending on what you do, because you never know what the patient actually means by what they're telling you they do. And so I think you have to be very clear with them that that is a risky practice. It's risky because of the synergy, and it's risky because of the alcohol as an extracting agent that pulls medicine out of a slow-release tablet in a dumping syndrome, and now exposes people to a much higher dose all at once of their medicine that's meant to last 8 or 12 hours. So they need to understand that. So this is a document that you can use at the time of prescribing as well as in follow-up. You can incorporate it alongside of the patient-provider agreement. And again, it's all about education, and it's all about expectations and being transparent with patients. You want people to really understand that these are specially manufactured medications. They are different from your usual thing. And a lot of times people think they understand what slow release or extended release or long-acting forms of medicine are because they've done that or been exposed to it with Pepsid or some other medication. This is a different process. This is a different risk. This is a different mechanism. And so you don't want them doing anything to the system. You want them to understand how important it is to take them as prescribed, because guess what? If you don't follow the instructions, you won't get the expected outcome. We've beaten it into your head that you shouldn't do anything to the capsules. You'd also be amazed at what people do with patches. Again, you don't want them cut. You don't want them put in strange places, and people will do that. That's another lecture. If the backing is foil or has any kind of metallic compounds, you can't get an MRI because of that. So again, it's an educational process. You should rotate the site of where patches go, but you want to be thoughtful about where the patches do go. And you don't put them on the area that's painful. You put them on an area that has an appropriate amount of adipose tissue and support so that you can absorb the medicine appropriately. And again, the same thing applies to the buccal film products that are now coming on the market. As you heard us talk about repeatedly, people don't follow the instructions. Another example of that is if you look at large database studies of companies that perform urine drug tests, 65% of those tests come back abnormal. That means that there's a substance present that shouldn't be present, or there's a substance missing that has been prescribed. So that's not just patients in substance abuse programs. That's general population being tested. 65% of people are not doing what they're supposed to do with these particular medications. Even if you say that some of those are false positive and false negatives, you still got a huge percentage of people. So that too comes down to communication and understanding what your patient's doing or not doing. There are many things that will lead to non-adherence. Obviously, ignorance in education, but also the regimen's too complicated. Whatever it is that you're asking the patient to do, it's just too hard. And people don't see that it really needs to be followed in that way. So they do it their own way, or not at all. In the world of chronic pain management, depression is very common. Depression is a huge comorbidity that's often missed, and depression is a huge reason for noncompliance because people just can't do it. They're overwhelmed or lacking motivation, and they're pessimistic about the outcome anyway, and so they say, what's it really going to matter? Side effects, obviously. People will respond to something that is aversive much more so than something that is silent. And so if you're trying to get somebody to have a sustained benefit in a chronic, relatively low symptom condition, and yet you give them something that causes a side effect that is terribly aversive, not going to happen. And also the treatment expectations. If your goal for treatment is different than the patient's goal, they will do different things with the medicine. If the way they think the medicine is working is different than yours, they will do things based on their beliefs. That's why it's so important to make sure that they have the right knowledge. Medication guides do provide information as well. They reinforce much of what the other documents provide, but also medication-specific information that patients can go back to and refer about side effects and other aspects of their use. There's always a lot of questions about should people that are on chronic opioids be driving, operating heavy machinery, how impaired are they? It's hard to know. Again, if you were to say to everybody, you can't drive if you take this medicine, nobody's going to follow that advice. And there's no way for us to monitor that. On the other hand, what's the risk mitigation? having somebody get behind the wheel when they've just started this medicine, when they've changed the dose and increased it, when they're having a difficult time and other changes are being made to their regimen, if they're medically ill and other medications or drug interactions are possible, you want people to understand that there's the risk that they will be impaired and that they will not be able to function at their usual level. In a very stable situation, this is one of the benefits of tolerance, that the medicines are less and less sedating or less and less likely to cause some of that, as long as there's no other changes. If you see somebody that's overdosed, remember the most obvious thing is that their level of consciousness is impaired. They look intoxicated, they look sleepy, they're having trouble staying awake. If you stop talking for a little while and just look at them, they kind of gradually drift off. However, there are other signs too. People that are breathing at a very low rate, a decrease in bowel motility, meiosis, all of those are signs that there are a lot of opioids on board relative to that person's level of tolerance. So, if somebody is in an over-medicated or overdose situation, you can reverse that with naloxone or other opioid antagonists. And there's now a lot of conversation about how should we make that available or how should we mandate that alongside of the use of these medicines. And again, reminding you that changes in dose, increases in dose, rotation to another opioid, and a special circumstance of starting somebody on methadone because of its slow progress toward a steady state and its likely accumulation in a person over time, those are all situations where somebody can be exposed to a lot of opioid very quickly and get into trouble. So you want to protect everybody, not just the patient. We've talked about storing these things in a safe place, protecting them from theft, disposing of them when you're no longer taking them or no longer need them, and not sharing them with other people. It's important to raise awareness in folks to get them to think about, well, just what is in your household? Because you may have other things there that are tempting people or that you're likely to take even though your doctor doesn't know that you still have them, and they could interact with the opioids. You should be keeping track of how oftentimes the refills are made and whether people are really on schedule or running out early. And you should make sure that if something's expired, you get rid of it, because there will be changes that occur in potency and likelihood of side effects. So we talked earlier about the disposal. We talked about the importance of these medicines getting out of the public domain. We won't reiterate all of those, but you should think about how people that are either ignorant of these medicines or people who truly are abusing them are likely to come into contact with them. People that have an addiction are very motivated. They're motivated to find the drug, they're motivated to get the result that they're looking for, and even if that drug is in the trash and has been mixed in with some of the most disgusting things you can imagine, they still might use it. And animals, pets, children, they don't necessarily think about that. They see a pretty pill and they think candy, or they see something and they eat it, and now you've got a problem. So, use a patient counseling document to outline these do's and don'ts of opioids and establish patient goals. Counsel patients about proper use, adverse events of opioids, particularly respiratory depression, non-adherence, which can lead to accidental overdose and poor pain control. Overdoses are more likely when opioids are combined with other CNS depressants. What are the most common CNS depressants that people are going to be exposed to? Alcohol, sleeping pills, muscle relaxants. They're all the anxiolytics. They're all medicines that these patients take on a regular basis. And the appropriate disposal issue.
So let's look about some general drug information about the opioid analgesics here. I say what you should do is pick one, learn about it, get comfortable with the doses, prescribing it, and put it on one good patient. Now, this is not the drippy drawer, draggedy patient that nobody can fix. This is the guy or gal that you think is going to be a good candidate, like Emily. Somebody who is really going to benefit from trying this type of therapy. So that's my suggestion on how you actually start about it. And you look at the drug-drug interactions. There wasn't an opioid I prescribed that I didn't go through the patient's chart and look at their functions, their liver functions, their kidney functions, what other kinds of drugs they were taking to make sure that I wasn't going to have an interaction. So, they're scheduled, and they can be misused or abused. So that should be, a key element in your thinking. You know that you've got some folks with adverse events, and the constipation is going to be a big one, as again we discussed. And the drug-drug interactions are going to be with the CNS depressants. Now, the CDC is saying no benzos and opioids. So what you're going to have to look at is, which I always say, which is most important to you, your pain medication or your benzodiazepines, and that's why it's important to go into the drug monitoring programs to make sure there's some other person prescribing for this patient who might be prescribing them, and you would be not know about it. The MAOIs, the diuretics. Diuretics can be affected by opioids. QTC prolongation with methadone, and they're thinking more along the lines of more opioids than they know, but for sure with methadone. And the methadone guidelines say that when you're starting a patient on methadone, you should do a baseline EKG to make sure that the patient has a stable heart rhythm, so that when you see changes, you're thinking, that's because of the methadone we've given them. And I just want to stress to you, methadone is a hard drug to work with. And so I would always start my patients on like 2.5 or 5 milligrams, even though the starting dose was 10 milligrams, because I wanted to make sure we weren't going to get into trouble, because the half-life is 72 hours. So when you start the first dose, you really don't get much until you're several days out. And I had this lovely pain fellow, and the nurses called me in a panic. They said, you have to come and see his patient. He's really having breathing difficulties. And by the time I got there, the patient was almost chain stoking. And I said, well, we'll go to ICU right now. We'll find out what happened. And so I went to the guy and I said, what was, well, the man had really bad abdominal pain. And so the GI fellow and I thought that we would start him on some methadone. So we started him on some methadone. We came back the first day and he said his pain wasn't any better, so we doubled the dose. He said in the third day we came back and he said, the pain wasn't any better, so we doubled the dose. I said, well, he's in ICU now and he's intubated. So you're going to have to figure out what went wrong, how you went wrong, and what actually happened with this man, because I think you got some splaining to do when he wakes up. So I think it's important that you understand that a drug like methadone has bad side effects with the QTC prolongation, can have a really highly sedating effect. So when I would prescribe it, I'd always call the pharmacist and say, what do you think about this dose? What do you think about that dose? So, grab a pal, have somebody, one of your colleagues, look at what you're considering doing. And again, there are the P450 interactions that you could expect. So we talked about common CNS depressants, potentiating the sedation, but the last column here is really interesting. It says, opioids and overdose deaths for CNS depressants, benzodiazepines are implicated in 77% of the cases. So you may not be aware that your patient is on them. The anti-epileptic and anti-Parkinsonian drugs, 65%, and antidepressants, 57%. So you never know. I get, they're not crime scene photos, but I get photos from the bedrooms of these people that have overdosed, and their nightstands are filled with bottles. And I'm sure not all the physicians who were prescribing those medications knew that somebody else was prescribing additional. So warn them not to drink alcohol. I had the guy fall and hit his head and have a bleed. So alcohol itself is involved in 18.3% of emergency department visits associated with opioids. So, it's more common than you might think. And what it does is it actually degrades the time release mechanisms in these medications. So the little beads that are inside the capsule degrade faster, the pill degrades faster, and it releases all the medication from a 12 or a 24-hour dose at once. So that is the danger with that one. So you really think, well, MAOIs, co-administration with opioids can increase respiratory depression, and I don't know that many people are actually prescribing these anymore. But they do have that. And this serotonin syndrome is something that you should be aware of. Now, I've only seen it once in my practice. I had a gentleman get very confused on the unit and start walking around very restlessly, and so they have cognitive or mental changes. They have abnormalities, but the psychiatrist told me, she said, he's got a serotonin syndrome. Now, you talked a little bit about this last time. Did you want to say something?
Sure. I think that this is similar to a neuroleptic malignant syndrome in terms of how it presents. In its severe forms, these people are really sick and need a monitored setting and a lot of hydration and supportive care. I too have seen only a handful of those cases in my career. I think what is more likely is that you see them in milder forms where the patient is a little confused, not quite all there, a little bit anxious or apathetic, and a little bit stiff or trembly. It probably doesn't happen a lot. The concern about this is probably overblown given what psychiatrists are doing to patients with medicines that have serotonin activity, because we will oftentimes give people very high doses of these medicines for other reasons, and we tend not to see it. It's the vulnerable patient, it's the patient on multiple meds, it's the patient who has other underlying neurologic problems or difficulties metabolizing medicines, and who is getting kind of multiple medications with serotonergic activity.
So yeah, even though it's not common, it's important that you understand that it is a potential. Can affect renal function. That's why I always check the renal function on my patients. And they can reduce the efficacy of diuretics by inducing release of antidiuretic hormone, which I don't think is very publicly known. So polymorphisms in the CYP450 can alter opioid metabolism. So you're going to have patients that metabolize medications very rapidly. You're going to have little ladies that you give a sniff of a medication to and they go out for 2 days. So the metabolism, the way the patients actually metabolize these drugs is very important. And I think you see here that there are some interactions that are particularly interesting. There are inducers and inhibitors. And some of the most common drugs show up there, phenytoin. Okay? Cimetidine. Some of these drugs are used commonly. So you look at this and you say, well, I don't know. So it's really important to understand when you're prescribing an opioid just what kind of effect it can have if the patient is on some kind of therapy. So here's Emily again.
Okay, great, thank you. I really feel much better about myself now. At work, I can think about work instead of how to avoid the pain. It's definitely made me a much more productive part of the team, which makes me feel really good about myself. Okay, one moment. And even the day-to-day stuff is better, like shopping and walking. I still have pain sometimes, but I can do what I need to do, and I don't have to talk about how much it hurts.
Okay, is that progress towards goals? Yes, she looks really good. So what you need to understand is a medication made a change in her life for the positive. She has to undergo all the monitoring, the compliance and everything. And if indeed she was not achieving her goals, what would we do? Taper her off because it wouldn't be something that would be positive for her. But she looks great. So you understand the adverse events and potential drug interactions, respiratory depression again, the interaction with the medications, And certain formulations should really only be used in opioid tolerant patients. I can tell you that, people came up with a bright idea to use them in postoperative settings. It was not a good success. It is important not to tamper with these opioid formulations, and I've had people do just about everything to them. Chew them, try to dissolve them. When I was a brand new pain nurse, they said, you have to come see this patient. We had him on a 50 microgram fentanyl patch, and he was so sedated, so we switched it to a 25. I said, okay, so I went up to the floor and I opened his gown and I looked, and they had taken the 50 microgram patch and cut it in half. They said, he's still so sedated, we don't understand. I said, well, you have spread all that medication across his chest, and it was just like a big, and the body took it in, and so it was a dose dump that way. So you have to be aware of these things and know the specific characteristic of each opioid and tailor therapy. And if you feel like it's too much for you, like I said, pick one medication, learn it very well, try it in a good patient so you get some kind of an idea of what the outcome could be.
I recently read that I think there's a study about acupuncture and massage that seems to help chronic pain, like low back pain and stuff like that.
Well, they really have a lot of trouble bringing it out of a Cochrane review because of the types of therapy they are. But, I personally, my palliative care physician was a acupuncturist, and he would do it. I've had acupuncture, and I like it. So massage, I think, is a good option. What about you? Do you recommend it?
Yeah, I think that when you think about these other non-pharmacologic therapies, you have to think about what it is that they're doing and what it is that they are offering the patient. And oftentimes what they are doing is promoting the patient being better informed about what's wrong with them and what they can do to help themselves, learning a technique, whether it's visual imagery or relaxation or yoga, becoming more aware of their body in a healthy way as opposed to an illness-focused or symptom-focused way, and then getting better at something, which promotes practice and function and moves them along. So I think it's a question of best fit. And some people are very open-minded towards things like Tai Chi or Qigong or yoga. And so you got to think about what that second person actually will engage with. Because, maybe there's another activity or maybe there's another form of non-pharmacologic management that he will take to.
I had a patient who told me that his pain management provider was aware that he smoked marijuana to help with the pain. What are your thoughts?
Yeah, so this is on everybody's mind right now because we are really in a state of transition and limbo about marijuana. There's obviously places that have passed it as medical marijuana only. There are other places where it's a legal drug. It's still considered illegal at the federal level. And I think that all of that is for society to figure out. I think when it comes to us, we have to understand what marijuana is and does to people and how it interacts with other things that we are prescribing them. And so it's a little bit like the alcohol question. Do you want your patient smoking marijuana and also taking opioids? And maybe taking an anxiolytic and a sleeping pill and a muscle relaxant, and now they're going to get behind the car or wheel of a car and drive. It is true that in chronically used situations, marijuana tends to decrease motivation and drive. And that's exactly what we don't want these patients experiencing. There is good evidence to show that marijuana is a gateway to use of other illicit substances and more potent substances and more disordered function. So again, it comes back to the function level. Is the patient functioning? Are they doing what they should be doing? If they're not, maybe the marijuana is something to consider getting rid of as opposed to saying, well, we have to accept that as a given.
So I myself don't prescribe marijuana, or I don't prescribe marijuana, but I don't prescribe opioids to patients who are showing positive with marijuana. because I feel it's too much of a risk. I like my license, my name's on the prescription. I don't think that I really want to go for the risk. But what I've seen some of the patients doing is using the CBD oil, which doesn't have the THC where you can actually put it on topically, so it's really controlled for the application.
I have a question. Can the handling of any of these medications, opioids, cocaine, cause a positive urinary drug test? A few years ago, I had a reputable ophthalmologist who was practicing in my building and came down for some drug testing, I guess for insurance purposes, and he tested positive for cocaine.
Yeah, so the whole thing about urine drug testing and other forms of drug testing, because now you can do swabs and you can do certain blood tests, et cetera, is that you have to know the lab and you have to know the test and you have to know what it can detect and what it can't detect and what are likely positives, false positives and false negatives. Patients will tell you all kinds of things. Oh yeah, I had poppy seed muffin today. Or, oh yeah, I'm on Zoloft and that sometimes, false positive for X, Y, or Z. The important thing is to go back to that lab and say, the patient is telling me this. I want you to consider that it's a false positive or a false negative. If you do a more sensitive test, you can actually see that maybe there is the substance present, but it's below threshold. Or people will come back and say, no, this is the profile of cocaine, period. It's nothing else. So I think it's better to know what you're doing and what's being done for you than just to react to the result and what the patient says and either fire them or excuse them.
One of the recommendations from CDC is don't give benzos and opiates together. How do you handle the patients who have been taking low-dose benzos, low-dose opiates for 20, 30 years, and they're not willing to come off either one of them?
Well, I think you're going to have to say that it's been successful for 30 years, wouldn't you think? And I think you're going to have to go to the very lowest dose possible on both of them. That would be my approach. What would you think?
Yeah, I think that, again, it depends on the individual patient, and there are situations where you would say, look, this is successful and low risk, and don't rock the boat too much, but be attentive and be cautious. I think there are other situations where you would say, we got an awful lot of people taking benzos that shouldn't be. And if anything is overprescribed, it probably is benzos, particularly in this patient population. Benzos and other sedative hypnotics are prescribed for muscle spasms, insomnia, and anxiolytics. And there was a Cochrane study a number of years back that said that they're completely ineffective for those things in this population. There are much better treatments for anxiety, both pharmacological and non. There are much better treatments for insomnia, including the treatment of depression and getting people off of a bunch of polypharmacy that is disrupting their sleep. And most muscle spasm is not spasticity, it's weakness, and people need more exercise and physical therapy.
What are your thoughts on trigger point injections as a non-pharmacological management?
I think for some people they work great. So it depends on the type of pain. So if you're going to do trigger points, it's kind of like 6 of one, half dozen of the other. You may or may not be successful. But for some patients, they do work well. What's your experience?
Yeah, in select patients, they can facilitate, and they should not be a standalone treatment. They should facilitate function, exercise, going to physical therapy, and getting stronger. If somebody is getting trigger point injections every month or every 6 weeks for 10 years, I think that's probably not a good practice. I think that, again, it's a way to, they should really be based on a good physical exam that says, I can palpate this nodule, or I can provoke this spasm, or find this trigger point activation, and then work on getting past that barrier.
How often do you do an opioid risk tool and patient agreement?
A lot of clinics set up a protocol, so you may be doing it every year again. So you may be renewing it, and it's a good chance to sit down and talk to the patient about, do you remember when we said this, or when we talked about this, and just kind of refresh what's in there. What's your practice?
Yeah, for the agreement, yes, at least every year. It's important to have people sign it. It's important to have a back and forth with patients about it. Not because you think signing it is going to prevent some disaster, but so that you're actually engaging with the person and they're listening to what you say. If you just drone on, they just sit there and say, when will this be over? You know, it's like a teenager. When will this be over so I can go out again? But if you're asking them questions and they're saying, really, will this happen to me? Or what should I do about this? Now you're problem solving together and they're working with you. I think that, you know, other aspects of the monitoring, like a opioid risk tool, there are other questionnaires that are tailored to ongoing care and monitoring people who are already on the medicines. The issue is, how often do you do those? Well, it kind of depends on the patient, and it's all about getting used to asking those questions. And at some point, you get pretty facile with that, and it just kind of comes out in the conversation. You don't necessarily need to fill out the tool.
I had a patient, 86-year-old woman with chronic osteoarthritis, who had apparently been on hydrocodone for years, just taking a couple 5 milligram a day. And when we started her off, she consistently came back negative with her urine drug screens, also on her confirmatory studies. So we had to drop her and tell her that we can't continue to prescribe them anymore. I think she's being honest with me. I think she's telling me she's taking them every day. And after hearing about the internet issue, I'm wondering if maybe her children, who are a little bit more suspicious, are substituting these pills of hers when she's not looking, and so she thinks she's taking her medicine when she's really taking a placebo. Are there organizations that we could send maybe a pill bottle to in such a situation to get them checked to see if they're legit or not?
I used to send all my stuff to NIH, so I was right across the street, so I could send like my morphine bags and stuff, and it was to protect the nurses when there was an issue. But I will tell you that some children think it's, I had a friend whose mother had Alzheimer's, and they just kept watering her wine down more and more and more. So it looked red, but she was really getting a lot of St. Augustine, you know, bay water in there. So I just need to tell you, children can do funny things. Her levels may not have been low enough. And again, her children may have been taking her pills and substituting.
When we try to take them off opiates, in most cases we switch it and then we hook them to this medication, and it would be really very hard to deal with them, and they crave for it. What is the best approach in regard to this?
Well, I think it depends on the situation. If you're switching somebody to methadone as an alternative to the opioid they've been on, hoping for better pain relief, you really have to give methadone for its analgesic properties 3 or 4 times a day, because analgesically, methadone is a short-acting opioid. Its half-life and its withdrawal prevention are long enough so that that's why it's used in drug treatment. You can dose it once a day or once every other day and keep people's receptors blocked from getting a high if they use on top of it. If you are switching people to methadone because you think they have a drug abuse problem and now you want them in an opioid agonist therapy program, then that really should be just one component of multidisciplinary drug treatment. And people should be monitored by specialists. If what they're describing to you is true craving, then probably they're not on a high enough dose, or there are other triggers that are activating the craving, or you don't have a good handle on what else it is that they're doing. If what they're describing is that they have more pain and the medicine is not working as well as the prior opioid, then it becomes a strategy of titration. The issue with methadone is it is just a very idiosyncratic drug as far as how to do a conversion. you really, really need to underestimate when you switch somebody over because of this long half-life and the accumulation that occurs. And the titration increments should be widely spaced apart to make sure that somebody is truly at a steady state before you say, this is the best we can do with this dose.
And some folks like to take, they think putting something in their mouth is helping them, so they like to take pills more frequently. So going to something that's more extended release really goes against their grain. They think that, you know, they should be able to take something more often, they'll feel better, but that is not the case.